So welcome. My name is Steve Bartels. I'm a professor of medicine at Mass General, and I happen to have the privilege of being the director of the Mongan Institute. For those of you who may not know about the Mongan Institute, we are made up of about 10 centers. We have over 100 research faculty dedicated to achieving health equity in the lives of people with complex health needs through research and training in population and healthcare delivery science. And so we view our work as completing the translational arc at MGH, which begins by others with fundamental and clinical trials research from bench to bedside. And our work spans data science to healthcare delivery science in the clinic, the community, the population, and globally. So if you want to find more about us, you can look us up under www.mongan.institute. So I'm actually really thrilled to have this opportunity to help kick off this new QUIIPS series, Quick Interviews with Interesting People, sponsored by the Mass General Research Institute, by engaging in a conversation with one of our faculty members and center co-directors at the Mongan Institute, Dr. Ingrid Bassett. And at the end of this, by the way, we'll have opportunities for question and answers. But for now, what I'd like to do is introduce Ingrid. She's a physician investigator in the Division of Infectious Disease. She co-directs the Medical Practice Evaluation Center within the Mongan Institute. She's an associate professor of medicine at Harvard Medical School and the Weissman Family MGH Research Scholar. So without further ado, I'm just going to jump into it, Ingrid.
Great.
Maybe we could begin with the beginning of your research career. How did you come to be a global health researcher? I imagine this was something you always wanted to be when you were a small child and aspired to when you sought out your research career path. How did this happen?
Great. Well, thanks for the question. I'm really excited to be here for this kickoff. I think there is some truth to the childhood idea. My mom is Peruvian, and I spent a lot of time in Peru as a child. And I think she always encouraged me to think about my place in the world outside of the suburb where I grew up. And that was really the first place where I got to see close up the differences in terms of how people lived and how much, people's financial and socioeconomic circumstances could affect their life and their health. When I started my research as a fellow, an infectious disease fellow, I had the luck of working with Rochelle Walensky and Ken Friedberg as a resident, and I thought they were really committed to mentoring and thinking about really interesting ideas. So I came to them wanting to do global health research. They mainly use mathematical models and simulation modeling as their methods, and I really was interested in collecting primary data from people, but they were really supportive and wanted to help me figure out how to pursue global health research. So we had a kind of momentous meeting that I remember really well with Bruce Walker, now from the Reagan Institute, who was already doing basic science research in Durban back when I was a fellow in South Africa. And we invited him for a meeting and told him, that I was interested in trying to do global health research and whether he could help make connections for me in South Africa. And he immediately got onto his phone. I think this ages me now. It was a BlackBerry, and called the superintendent of the hospital where he had been doing work and asked if it would be okay for an infectious disease fellow to come and spend time there doing research. So that was a really fateful meeting and a good example of kind of sponsorship and someone really, moving the needle for me to make this possible. I first went to South Africa in 2004, and it was just a really exciting time to be there. It was a confluence of a lot of good factors. One was that I ended up at McCord Hospital in South Africa, where it was a very visionary place. They were trying to move the needle on how to deliver care. And this was 2004 when the US President's Emergency Plan for AIDS Relief, or PEPFAR, was first starting to fund HIV care in South Africa. And so there was this real excitement there that HIV was going to go from being a disease for which very few people were able to get treatment in South Africa to this very rapid scale up of trying to figure out how to diagnose and deliver care well to people, with funding coming from the government and other places. And so it was a time when, research priorities were really shifting, and there was a lot of pressing need to figure out how to deliver care to people living with HIV at the time. And I think for me, one of the things I learned from that was just having mentors who are invested in you and in helping you get where you want to go. Is probably more important than whether they use the exact same methods you use, or are doing exactly the same kind of research you want to do. So I think for me it was a bit of serendipity, a bit of being in the right place at the right time, and a bit of having really dedicated mentors who wanted to help me make it work.
Yeah. So the stars were really kind of aligned for you in a way, but you had to come up with a research question, which is fundamental to any science. And so how did you figure out what was the most important thing to ask, and the thing that was going to establish a real impact in terms of the setting and the challenge of HIV in this under-resourced setting that you were, first parachuting into, and different from your mentor's research?
Well, I think at the time, one thing that we were thinking about was how did people enter the HIV care system? So if we can go back to 2004. At that time in South Africa, people were tested for HIV in standalone voluntary counseling and testing sites that were separate from the general healthcare system. And so what we first started out with was a project related to offering routine HIV testing, and that is people being tested regardless of what they're presenting for their healthcare for. We kind of take that now as for granted that that's a good idea, but that recommendation from the WHO and the CDC came later. So that was how we started. I did a project related to routine HIV testing in the outpatient department at this hospital in Durban. And for me, it was a lot about trying to listen and understand what the clinicians viewed as obstacles to being able to do this, what the patients viewed as obstacles for being able to do this. One of the things we saw is that when people were referred to these separate voluntary counseling and testing sites, only about a third of them actually made it to be tested. And I think that moved the needle in terms of convincing colleagues at McCord that this was something we should try. And I think we found there were, some good things and some bad things. There was a lot of political will to do this, and we were able to launch a routine HIV testing program and showed that it was acceptable to the patients. But we also saw that even making the testing available in the outpatient department didn't necessarily lead to people going on and taking the subsequent steps and linking to care, the care that they needed. And so that really set me onto a trajectory for thinking more about strategies for how to help people link to care, what made it hard for people to do that, what could we do to make things better.
So what sort of science would you call this?
Yes. Okay. Well, I think I've been kind of grandmothered in as an implementation scientist. I think HIV is fortunately over time has become easier to diagnose and easier to treat. So for many people, they can take one pill once a day and suppress the virus and often achieve a normal or near normal lifespan for their age and comorbidities. So that's incredibly exciting, but we're still, as a globe, struggling, I think, with how to make sure that people learn their HIV status and link to care and stay in care successfully. So trying to think about strategies for that has been a lot of what I've been working on. And over time, I think, I started with research that was very much tied to doing research in a clinic or in a hospital. But in resource limited settings, a lot of times the government run or state subsidized healthcare system can be really crowded and congested. And so over time, we have shifted toward thinking about what kind of things can we achieve outside of the brick and mortar healthcare system. So things that can be done in the community.
Yeah. So sometimes people wonder about why do this research in other settings? And why should we be investing in research in global health? And does any of what you do translate back into our local system and lessons learned? Thoughts about that?
Yeah, I mean, I think there are a lot of reasons to do this research in global settings. I mean, I do think that, certainly when I first started, I think were two people who were board certified in infectious disease in the province where I was working. And so the extent to which I felt like my training could be really useful. At that time, I just felt like a kind of moral imperative. We were treating people with HIV in the United States in ways that were not being done in sub-Saharan Africa. And so trying to put my energy and excitement about increasing access to care into places where people weren't getting it was really important to me. But I do think that a lot of strategies, a lot of the questions are really the same wherever you are. How do you design the healthcare delivery in a way that is appealing to the people that need it, and that I think we see, for example, with COVID, mobile COVID screening, and colleagues that I work with in South Africa have been doing mobile HIV screening since 2008.
Yeah.
So I think a lot of the innovations and resourcefulness that people have drawn on to come up with strategies in other parts of the world have a lot of application to solving similar problems in the United States.
So let's talk about that a little bit. So, how have the work that you did originally in South Africa, how has that translated into the work you've been doing recently in COVID-19? Because you just mentioned that many of the lessons that you learned there had to be teed up very quickly and rapidly in this setting. And we've heard so much about the terrific work that was done in the lab around understanding the pathophysiology of COVID-19 and the genetics and also developing vaccines. But this is about how to deliver testing and vaccines and care across a very challenging and diverse setting in the United States. So how have you attacked this, and how have you thought about this in the work that you're doing now?
Well, what I was tasked with as part of COVID times, I think many of us have the familiar refrain of finding ourselves doing something really different from what we were planning to do over the last year. I think my experience with observational cohorts and with primary data collection led my then boss, Rochelle Walensky, chief of the ID division, to ask me to help out with developing observational data collection at Mass General. I think she had a lot of foresight because as the COVID-19 pandemic was starting to unfold, she quickly steered the ship towards clinical trials infrastructure and clinical guidance infrastructure. So developing teams of people who could help launch clinical trials really quickly, and who could offer guidance and discuss difficult cases on a regular basis. And that was something that the ID division really, I think, jumped into with a full heart, and is still doing now. I drew on a lot of people working in electronic health records and primary data collection at MGH to help develop the MGH COVID registry, which really involved getting input from people from lots of different divisions and departments in the hospital really quickly to be able to launch data collection. And I think for me, it was a little different than my usual research in the sense that it was domestic, but also that I was really viewing it as developing a resource for other people to use. And so that's been something that now we have a manual and electronic data that's really research ready, high quality data that can be used by anyone at MGH, and it's being managed by the MGH research computing team, so anyone can go to their website and request access to the data. We wanted it to be data that could be used for research, obviously, but also at times it's been used to answer questions about what's happening with mortality in the hospital in COVID, or how many people do we think might be eligible for certain clinical trials based on the data that we had. So I think, being able to move swiftly, being able to ask for help and manage a kind of complex REDCap operation were all things that I had been doing in South Africa already. So it was a good match for this task.
One of the amazing things about COVID-19 that has been the positive part, I guess, of the story has been the way in which science so quickly pivoted and moved. And yet, as you mentioned, it really takes a village. It takes team science. And maybe you could talk a little bit about what it's been like to work with people in completely different methodological disciplines and what it means to be a team scientist. And I think, and part of that is because I think that's probably the greatest potential at Mass General is we have an incredible breadth of scientists spanning fundamental to clinical to delivery and population science and data science. How does that work? And how did you find that experience of suddenly being thrown into this so-called agile, accelerated, research environment that had to kind of stand up something quite quickly and tap into each other's different experiences and communicate quickly to get something that actually was operational? How does that work?
Well, I think one of the things that has been inspiring about COVID-19 is the extent to which, for a certain period of time, all of the scientific might really in MGH was focused on this problem. And so what was amazing to me was people stepped forward and said, I'd be happy to help. I'd be happy to look at the instrument. I have ideas or suggestions. People who also offered up their own help or help from team members to perform all these chart reviews, which was really a gigantic task. I definitely think the silver lining has been talking to people that whose paths I hadn't crossed before, people in other divisions in the Department of Medicine, Sean Murphy and the team that works with the electronic health record, Andrea Folks in biostatistics, who, was all these people were really quick to say, let's join forces and make this happen together. So I think that sort of level of collaboration and, kind of breaking down the silos was a really
I think you've frozen for a second there. There you go.
energizing part of all the institutions in Boston where, sorry.
It's okay.
We saw it with other institutions in Boston also sharing their data and or sharing their best practices for how to collect data and to make registries.
Yeah, that's great. And how has your Research Scholar Award helped in this whole endeavor? I know that's part of what I said in the introduction, and it's really one of the wonderful things about Mass General supporting some of these Scholar Awards.
Yeah, I think this is really important because for most of the time your funding is tied to a specific project and you're reporting to the NIH about your progress, and that's helpful and great, and a lot of us make our careers from that funding. I think the nice thing about the Scholar Award is that it's really more an investment in the individual investigators and the idea that they trust you to decide what direction and what needs to be done in your own career. So for me, the COVID work took a lot of effort and time, and I felt I was able to devote time to that because I had this more flexible funding. So it was a major boon. At any time, but especially in this time where I found myself doing something that I hadn't expected.
And I know you've also had K awards, both an initial K award and a K24, a mentoring award. Is that right? Also,
yeah, I think from the mentoring perspective, the K24 is a dedicated award for mentors doing clinical research. And it provides support for the mentors effort, which is also fantastic and really allows a mentor to dedicate time and hone their skills and also take on more mentees, have more capacity for mentoring. So that's been fantastic.
So I want to remind our listeners that if you want to submit a question in the chat, please do so. But I'm going to turn to mentoring. We've talked a lot about your science, your career development. we've kind of touched the issue of mentoring, but maybe you could talk a little bit about how mentoring worked for you in terms of your mentors first, how you figured out how to differentiate yourself a bit from your mentors, yet keep linked enough in terms of the overlap so you were grounded, but pursued something that was different as a scientific enterprise. So you added value while also building off of, standing on the shoulders of your mentors. And maybe you could talk a little bit about that.
Yeah, I think, I think having mentors that are invested in you as a person and as a researcher in your own right is just so important. I definitely felt like my mentors, both my peer mentors and the mentors, ahead of me in this career, I felt that they were really looking out for me and my own development, and not, having me do their work or try to fulfill what it was that they wanted to accomplish. And I think that's really important. I was lucky because I really had great mentors. And while we think about some of the same problems, scientific problems, because the methods are different, that helped me distinguish myself from my mentors. I also think having co-mentors and mentors with compatible expertise is really important. So, I worked with some great behavioral scientists, for example, who have been helpful in thinking about developing and evaluating interventions. And that's something that is not so much part of my mentor's primary work, but getting that additional mentoring from outside has been helpful. Working with the biostatisticians and data analysts, also, I've learned a lot that way. But I think having a different kind of methods toolkit has helped me distinguish myself, and also, spending time at a different site at a in a global health setting has also made it possible for me to carve out an area that's different from what they do, but still completely compatible with what they do.
And now that you're a mentor yourself, I know you mentor many people at the Mongan and elsewhere. What are the most important things that you think about passing on? What sorts of wisdom do you pass on to your mentees that you've kind of accrued over the years that you think are really important for early career investigators to know about and to think about as they start their careers?
Well, Rochelle has this plaque on her desk that says, "Hard things are hard." I think doing research is an incredible gift. There's so much autonomy and creativity involved, but it's also, it's hard. There's a lot of uncertainty. You have papers rejected, you have grants rejected, and I think trying to not take it personally and, really share both your pains and your joys with other people is really important. I think there has to be a certain amount of humility. I definitely think of the global health realm, but really anywhere that you're doing research, you have to be able to listen and really understand what the problems are that people are facing, and use those to help frame your questions and your strategies. And so I think, not assuming what the right answer is when you go into a meeting, but being able to really listen and seek counsel from people who are grappling with these issues, be they the patients or the providers, and thinking about what are the most important questions. Mm-hmm. I think you should work with people you like. Life is short, and I think seeking out a kind of micro environment that makes you happy, where you feel supported and where you are supporting other people, I think brings a lot of joy to a career that has a lot of ups and downs and sometimes has setbacks.
Yeah, and as you know, I happen to be a psychiatrist also, so I'm going to ask you about balancing life and work. Could you comment a little bit on that? That's a tough thing for many of us at MGH, I know. And how have you navigated that? And what are you telling your mentees about that, particularly not only in this COVID context, but just overall?
Yeah, I mean, I'm still struggling with that. I think, what's been important for me has been that my partner is someone who's been supportive of me doing research in the global health arena. And like my husband, when we had a sabbatical, we went to South Africa together. And so he's supportive. And I do think that's important because, you don't want your job to create friction at home, or you want to try to minimize that. I think trying to really draw lines and figure out what's important and focusing on those things. I am the parent who signs up to bring like the juice boxes to the class breakfast, and not, the fresh baked goods. And so I think really figuring out the important thing is like that I'm at the class breakfast. And so trying to figure out, what are the key things that I really need to make
Mhm.
happen, and then be willing to let some of the other things go.
Yep.
But I think this is, this has all been magnified.
Sure.
All been magnified during COVID. So this is definitely something I talk with my mentees about in terms of, getting up and not eating dinner in front of your computer, and trying to just to make time as best you can, even if it means some things take longer, because it really is a marathon. And wanting to pace yourself in terms of making time to do the things that you like, and making time for the people that you love.
So we only have 1 minute for the last question, which I'm going to take the prerogative of asking. What's it been like to have your mentor go to run the world at the CDC? Losing your primary mentor, who I guess you were her first mentee, I think, if I'm not mistaken. And so what's that been like for you? Yeah. Have Rochelle Walensky leave us and leave you behind.
Yeah, I think it's been really bittersweet. I'm very proud of her. And I think in the infectious disease community, we all breathed this huge sigh of relief in a way when she was named, because we thought, all right, this is a person who's going to be a clear communicator. She is not going to be, swayed by politics. And she, is going to be a really steady hand at the tiller. So I think we were all really excited about that. At the same time, it has, it's been hard. She's someone who I could always go to, with a question: should I pursue this opportunity or let it go? Or, how do I weigh these different things in my life? And so, I think it's a lot of pride and a little bit of sadness.
I know that's how all of us feel in the Department of Medicine at the Mongan Institute and across MGH. We're both proud and delighted for the country, but we all miss her. But we have you now as a new co-director of MPEC, which is just terrific. It's filling some difficult shoes along with Ken Friedberg, but we're just so delighted to have your terrific work. And it's been just really enjoyable to hear you talk about your career, and really want to thank you for this interview. And thank you for talking about your science and how you think about things for other people that you're mentoring. So with that, thank you, Ingrid. It's been wonderful, as usual.
Thank you.
And I want to thank all of you who listened in and saw this, and thank you to the Mass General Research Institute for this new series, QUIIP, and I look forward to future interviews from others across the scientific spectrum. Good day. Have a nice day, and take care. Bye-bye now.